Good evening, everyone. Let me start by introducing myself. So my name's Suzie Collins. I'm a clinical psychologist. I'm actually based out in Western Queensland, but offer both online and in-person therapies. Today I've been asked to come and talk to you all around ADHD. And so my topic around understanding ADHD in children actually covers a couple of different ways of looking at ADHD and what that actually might entail. So we'll start with having a bit of a look at the agenda we're going to cover today. So to start off with, I'm going to talk a little bit about what is neurodiversity. It's this term that started to being used quite a lot in this field. And so I wanted to share a little bit about that. And as part of that, I want to talk about the different models that are available or that view ADHD and some other mental health disorders in a different way. So we'll look at the actual medical model first. Then I'll just do a really small section around the neuroscience around it. And then we're going to have a look at the social justice model, which is where the neurodiversity concept comes from. Then we're going to talk about the benefits and the uniqueness that a child has based on their qualities. And then we're going to also consider some ways that you as parents and caregivers might be able to support your child. So let's actually have a bit of a look at, what is neurodiversity? What is this term that everybody's been talking about? So neurodiversity is a concept that all the neurological differences that occur within human brains is actually just a natural variation, and that each brain type or brain style actually doesn't have any deficits within it. They're just different brain styles that use different ways of thinking and processing information. And if we have a look here at this slide, it actually talks around a whole range of different disorders, and we'll talk about those shortly, that might fall under this umbrella term of neurodiversity. And there's a whole range of different things that might fall in it. And in essence, because they're just different brain styles that children and adults actually have. So let's explore that a little bit further. But to start off with, we're going to really have a look at, when we think about this neurodiversity umbrella term, there's two, sort of distinct types of brain style. And so we talk about neurotypical and we also talk about neurodivergent. So a neurotypical is the brain style that our world that we function in is actually designed around. So our world is designed around people who need to go to school, they have to learn specific things, they sit in a classroom, they then go and do some sort of further training, usually get a job, stay in that for long periods of time. Somewhere along that line, they buy a house or you start families. You might invest some funds, and then somewhere along the end of that spectrum of life, we retire. But I guess when we talk about that world, the world that we live in isn't always designed for all brain styles. It's really designed for what we would typically call that neurotypical. So let's consider the different ways of explaining what that might mean. So as I mentioned in the agenda, we're going to talk a little bit about what the medical model is versus what the social justice model is. So the world we live in, as I mentioned, currently uses the medical model to determine if your brain style is good or it's not. And this model actually involves diagnoses. And it also uses what we call a deficit model. So it's really looking at what are all the things that are wrong with this brain. How does it work, or how does it not function as effectively as a neurotypical brain? But the other model that we'll also talk about today is what we call the social justice model or the social justice movement. So that particular model sees all of our different brain styles and functioning as non-pathologizing, and that all those different brain styles actually just have strengths and weaknesses, as all human beings have. And so it's just different variations in those brain styles. So let's have a look at the medical model and how that's useful in our world. So the medical model is generally used by most government departments. So when we think about the education system, we think about the NDIS system, Centrelink, and then lots of the classic health professionals such as our GPs, our paediatricians, and our psychiatrists. They all function under this medical model, and then these government departments actually require the medical model to be used in order to support their funding or services that they provide. Now, if we actually think back about what a diagnosis actually is, diagnosis is this label that's used to describe a cluster of symptoms that someone might present with. And that label then, or that diagnosis, helps the people around that particular person to understand a little bit around what their behaviours are. So, for example, if someone was diagnosed with depression, we know that what we're likely to see in that particular person is a loss of interest in activities they used to enjoy, some deep sadness going on, and a range of other things that are similar that are symptoms of depression. Diagnoses not only are used to describe those symptoms and help us understand how a person might be presenting, but they're also actually used as a line to determine some funding and services that they need to have. And that's actually really important because we know funding and services are not these unlimited buckets that can be used. And so we have to draw a line somewhere. And so these departments then decided that, well, if somebody meets the criteria of a particular diagnosis, then perhaps they can be eligible for our service or our funding that we can provide. Now, the medical model uses diagnostic labels that are identified through either one of two manuals that are used. So we have the Diagnostic and Statistical Manual for Mental Orders, and the latest version of that is the 5th edition with text revision. Or the other one, and so the DSM is actually, it was created by the American Psychiatric Association, and so they sort of developed that and put that criteria together. And then the second manual that someone may use, the medical model uses, is what we call the ICD. So that's the International Classification of Diseases. And that was actually put together by the World Health Organization. So both of those manuals are actually used to create diagnoses, and they each have quite similar criteria, but they're just two different systems or manuals that are used. They are quite similar. So let's have a look at some particular diagnoses. And today, we're obviously focused more on children. So I really just wanted to have a bit of a look at the different diagnoses that might fall under what we call neurodevelopmental disorders. So some of the specific disorders that fall under that category is what we call one of them is the intellectual development disorder. So they might be the children that may have some difficulties with learning or their intellect, so difficulties with reasoning and doing things quickly. Second one could be some type of communication disorder, and there's a few different types of that, but I guess the most common one is probably a speech or language disorder. So there might be some difficulties in how they're speaking or the actual development of their language skills. So they fall under the communication disorders. We also have the autism spectrum disorder, also known as ASD. And we also have attention deficit hyperactivity disorder, our ADHD, that we're going to talk about today, or that's going to be included. We also have specific learning disorders. And so there are 3 different types of those, and we'll talk about them shortly. Specifically, I guess they're usually known as, one of them is dyslexia, that I'm sure you're all familiar with. There's also dysgraphia and dyscalculia, but I'll talk about each of those shortly too. And then the other one that falls under neurodevelopmental disorders are motor disorders. So whether that might be dyspraxia or even some sort of Tourette syndrome, so those different tics that might be available, that all fall under motor disorders. So they're just some really common ones that fall under the neurodevelopmental disorders. So let's have a little bit of a look at the actual criteria that needs to happen. So each of those manuals that we talked about before has this set criteria that needs to be met in order for a diagnosis to be received. And so what makes it really tricky is that there are a number of symptoms that children present with that actually fall across a number of those disorders that I just talked about. And so it's actually really important to make sure that we actually ensure that the child receives a really comprehensive assessment, so that we can actually identify which specific disorder might be going on for that particular child, or perhaps there might be a couple of them that are existing. And so again, it's really important we can make sure that those diagnoses are made correctly, because different diagnoses have different treatments and they also have different medications around them. And so again, in order to meet that specific criteria, there's usually a whole range of deficits that need to be identified for them. And so because today's about ADHD, I'm actually just going to go and have a look at the ADHD. I'm not going to look at the specific criteria for it. We're just going to have a look at some of the things that a child may present with. And we're also just going to have a look at, within ADHD, there are actually 3 different types of ADHD. I know some of you may be aware of, we used to have one called ADD and one called ADHD. So when the new DSM-5 came out, that was all clustered under the one title or the one diagnosis of ADHD. And then there are these 3 different types. So when we consider those different types, the first one is what we call inattention type. And if we were looking at a child's behaviours to see whether or not it might have met that criteria, we're really looking at their ability to remain focused and to concentrate. Perhaps they might be making numerous careless mistakes. They might appear to not be listening. Perhaps they're not following instructions, or they failed to finish some tasks. They may have poor organisation of those tasks, trying to work out how to complete it, or they might have poor organisation of just their belongings. A child who's experiencing inattention might also have some poor time management, and they might avoid or dislike tasks that require sustained effort. So sometimes it can just be really exhausting and tiring to maintain their attention on tasks, and so they might start avoiding things that are too difficult. They're often losing things and are easily distracted and often quite forgetful. So there are some of the things that might be presenting if a child may meet the criteria for inattention. The other type is hyperactivity and impulsivity. And so you might observe a child who might be a little bit fidgety, perhaps squirming in their seat, not able to actually stay in their seat when they're expected to stay seated. Perhaps they're running or climbing when it's inappropriate, unable to play quietly, and often feeling like they're just on the go all the time. Hyperactivity and impulsivity also often presents with excessive talking. So there might not necessarily be some of the other symptoms going on, but excessive talking might be enough that meets that criteria. Perhaps they're blurting out answers before questions are even finished, or they might be interrupting others. And they also might show some difficulty waiting their turn. And sometimes it can be really tricky because some of those symptoms are also really common in children below school age, which is what you guys are working with at these centres. The third type of ADHD is actually the combination of both inattention and the hyperactivity and impulsivity. So again, it can be really tricky, and it requires a really comprehensive assessment to determine which type of these, including the combined type. And it's also important to identify whether or not perhaps some of these symptoms are just normal developmental processes that are happening. And we also know that children mature and develop at different levels, so we need to be mindful of that. And we also know that some of these symptoms also fall into other criteria. So again, really important to make sure that we can differentiate between those as we need to. So I'm just going to have a look at some of the things that we might notice with a couple of the other disorders that I mentioned before. So the next one we're going to have a look at is ASD, or the autism spectrum disorder. And so when we think about this particular disorder, it's a child is likely to present if they're having difficulties with communicating and socialising with others. So they might find it difficult to engage in back and forth conversation and that reciprocal interaction. They might have reduced sharing of emotions and their interests and what's going on for them. They might have difficulties initiating and responding to social connections. So they might find it difficult to go over and engage with their peers in the playground. Or if someone is actually talking to them and trying to engage them in play, they might not necessarily have those skills to respond to that and again have that back and forth or reciprocal interaction. They might have difficulties matching their emotions with their facial expressions. Perhaps there's some poor eye contact, or their body language doesn't match, or they're also having some difficulties with their body language and gestures and understanding what that is in other people as well. They might have a lack of interest in others and making or maintaining friends, so are happy to play on their own. And again, we also need to check whether or not that's also developmentally appropriate. I'm sure you've seen children engaging in parallel play. That doesn't necessarily mean that they have autism or that they meet this criteria. Perhaps they just haven't reached that developmental milestone yet. The other thing that might be happening for a child is difficulties adjusting their behaviour for different social contexts. So that's generally the main things we would look for around communicating and socialising. But the other part that's important for an autism diagnosis is just checking around what their behaviours are like and whether there's any repetitive or restrictive behaviours or interests. So they might, so that might look like some repeated use of a particular movement that might be going on. There might be some things that they play with over and over, or it might be some words that they say over and over, or it might actually be copying somebody else's words. They might find it really difficult to be flexible around routines, and when the routine changes, find that really difficult to cope with. Or perhaps they have these rituals that need to be followed all the time. They may also experience some really intense focus on a particular interest, and they might also have increased or decreased sensory concerns. So whether or not that's they're seeking lots of sensory input, and whether that might be specifically around touch or smell or taste or sight or hearing as our five senses, or they may actually try and push them away if they're being overstimulated by those things. And so, as you can see, there's some parts of this that might actually fall into some of those motor disorders as well, and we need to make sure that we can differentiate between those. The next one we're going to have a look at is the specific learning disorders. And so there are 3 types of specific learning disorders. And what's really important for each of these is they actually have to meet a specific criteria of being below what is expected for their particular age. And there are some set criteria, but that's what the assessment is about, to determine that. And the 3 different types of specific learning disorders. So as I mentioned before, we talked about, or I mentioned dyslexia, which is quite a common term used by many people, but it's actually an old term under the criteria or under the diagnosis label within the DSM, and it's actually called an impairment in reading. And sometimes it looks like an inaccurate, slow, or effortful reading. There might be some poor comprehension and perhaps some poor spelling. The second one I mentioned was dysgraphia, but again, that is now known as an impairment in writing. And it's usually presenting as difficulties with writing, and that includes both poor grammar, or punctuation, but also poor structure and organisation. So how well they can structure their sentences, how well they can structure their paragraphs or their essays. But we also have to make sure that the child's been exposed to the teaching that goes with that. And the last one is an impairment in mathematics, and what used to be known as dyscalculia. So that usually presents as difficulties with mathematics, and it can be across a number of areas. So actually the number itself and understanding what numbers mean, our actual number facts or our times tables, having some difficulties with that. Perhaps it's around just difficulties with calculations, or just that poor reasoning of problems. So when they're presented with something, they might just really struggle to understand what that actually means from a mathematical point of view. So there are 3 different types of specific learning disorders. And although I mentioned quite a few that fall under that neurodevelopmental disorders, today they're just the 3 I wanted to share as the most common, I guess, that usually interferes with a child's learning processes. So if we have a child who actually may be presenting with some of these concerns, so what do we do now? What's the next step? So I guess from a learning perspective as educators within a system, I guess it might be about perhaps raising some of these concerns with the parents to let them know what's going on, so that then they can go about having their child assessed to see whether or not they do actually meet one of those criteria, or perhaps they don't, and it is just developmental delays, or just that they haven't reached that level yet. So whether or not you want a diagnosis for your own information, or whether it's needed for a government department, the process is generally pretty much the same. And so the first step would be for a parent to engage with their GP and share what their observations and concerns are around their child's development. If the GP then has some concerns around what that might be and wants to investigate that further, there's a few different options that can be taken. The first one is you could actually refer the child, or the GP can refer the child to a paediatrician for assessment and diagnosis. They may perhaps want to refer to a psychologist for the assessment and diagnosis. But I guess there's a couple of disclaimers that go with referring to a psychologist. So the first one is, if you are actually seeking a diagnosis that can be supported or treated with medication, and not all of them are, it's actually probably best to engage directly with the paediatrician for the assessment and diagnosis. And that's because some paediatricians won't actually accept. Well, it's not so much that they don't accept a diagnosis from a psychologist. I guess from a prescribing perspective, if a paediatrician needs to prescribe some medication, then they are more likely to want to do the assessment themselves to make sure that they are aware of all the things that are being presented. So some paediatricians will accept the assessment by a psychologist and will then just use that data to confirm the diagnosis and then be able to prescribe as needed. But as I mentioned, some paediatricians want to do that themselves and they won't accept any other data. The other side of that is not all psychologists actually do assessments and diagnosing as part of their scope of practice. Although if you were looking for a psychologist to do that, if you looked for a psychologist that had an endorsement, such as clinical psychology or the education and developmental psychology, or even a neuroclinical psychology, they will usually be the ones that that do assessments and be able to provide a diagnosis. In relation to adults, I'll just pop this one in there, or any children that are actually over 16, most paediatricians probably wouldn't see someone new at that age, and so it's probably best to actually then get a referral directly to a psychiatrist for that to happen. So I think the main part in there is that it's all about making sure you make contact with your paediatrician to decide whether or not they want to do the assessment themselves, or if they're okay to consider and look at the data obtained by a psychologist. And then you can go ahead and have the assessment done. I guess what I've done in my practice around that is just that, asked clients to contact their paediatrician to see whether or not they'll accept or consider the data that I can collect and present, or whether or not they want to do it themselves. And often what I find is they're quite okay to accept somebody else's data. And what also happens is usually it's a good 6 to 12 months to get into a paediatrician. And so I can jump in and collect all of that data and have everything all ready so that when the patient turns up to the paediatrician for the appointment, all of that data and information is there. And so then the paediatrician can have a look at it. But every paediatrician works differently, so just make sure that you check in with yours to see what the best way is for that to happen. And then once you've been able to have that assessment and diagnosis completed, the next step is you'll generally receive some sort of letter or a report that's identifying that diagnosis. And then that diagnosis or that evidence then is actually used to submit to various departments. So I just want to have a brief review of some of those. So the education department, so again, different schools have different processes, but the majority of schools that I found in Queensland go through what's called a verification process. Now, Education Queensland have recently changed this process, and that they don't do a verification process because they use what's called the NCCD. And I can't recall what that stands for. I just know it's the NCCD. But what it actually does is it assesses all the children within that school to have a look and see what their educational needs and supports are that help them get the best out of their learning in a school environment. So as much as the diagnoses can be helpful, they're not always required. So again, check in with your school or the school you're thinking about sending your children to determine whether or not a diagnosis needs to be made in order to access the curriculum. For Centrelink purposes, so usually most people are looking for a diagnosis when they want to apply for the disability support pension. Now, there's more that needs to be met to be successful in a disability support pension. There's a whole range of requirements, and a diagnosis is just one of those. So again, important to make sure that you're familiar with all of the information that's required in order to make that application. Similarly with the NDIS, the first process is an access application. The NDIS, though, is actually based mainly on functional capacity, and so just a diagnosis isn't enough to access funding. And so in addition to an assessment for a diagnosis, there also needs to be a functional capacity assessment. And so I guess, you know, when you go and see a psychologist or your paediatrician, it's really important that when they do that assessment and find that diagnosis, that they're aware of what the purpose of the actual assessment actually is, because then they can tailor the report to address the needs of whichever education system they're using, or which Centrelink process they're going through, or if it's for NDIS purposes. So most people who are doing assessments will be familiar with these services or these government departments, and hopefully are skilled in making sure they address all of the criteria for each of those as part of the assessment. And I guess that's the other advantage of a psychologist, is that it will expand the assessment report into some of those other areas that are required. Whereas often a paediatrician or a psychiatrist will make the diagnosis for medication purposes, but not necessarily for the other government departments. So it can be really helpful. So I guess that sort of brings us to the end of the medical model and that process. So the next bit I just want to talk about is this little tiny bit around the neuroscience. So from a neuroscience perspective, there's some research that's found that there's actually different ways that brains function. And this particular research has shown what's the difference between that neurotypical brain and that neurodivergent brain that we talked about. And it suggests that those differences are actually how our brain updates our experiences. So a neurotypical person generally anticipates a particular response for a situation. And when that response is different, it can actually update the system or the brain to expand its anticipated outcomes for that situation. However, a neurodivergent brain finds it difficult to actually update that system and finds it really hard to anticipate or have that flexibility around how a situation might be different. And so if it's unable to update the system, it's constantly anticipating the same response for the same situation over and over again. And I guess this little bit of neuroscience actually explains that notion that neurodivergent brains like routine, because the system can't update the changes. So if we keep routines in place and we know outcomes from particular situations are the same, then we don't come across this difficulty of updating the system. That's my tiny little bit on neuroscience. So let's have a look at this social justice model that's come from the social justice movement. And so sometimes it works with the medical model and sometimes it actually works against it. And I think the biggest change that happens in it is all about the language, and very much around that the language is used to describe their strengths and weaknesses, and that it's a real focus on their identity of who they are rather than this specific diagnosis. And so this is where we're talking about that neurodiversity or that neurodivergent person. So some of the terms that fall under that neurodivergent umbrella are what we would call autism spectrum differences. So it still is ASD, but it's autism differences. And many people actually identify as either autism or an autistic person. And I know there was a stage there where it was very much around, we don't refer to the person as an autistic person, but it's a person with autism, so putting the person first. But in fact, I guess what we've found within this model is that every person has their own preference about what that is. And so if you are working with a family who may identify within the neurodivergent spectrum, then it's really important to check with them, how would you like me to refer to your child's autism? Again, ADHD, attention deficit hyperactivity differences, or often referred to an ADHDer. We have specific learning differences and perhaps some movement differences. And I guess in essence, the whole process is about removing the word disorder and just replacing it with differences, because every person is just different and it's not an impairment or it's not something wrong with their brain. It just functions differently to other people, as everybody's does. And so let's have a look then around those differences between diagnosis and identity. So if we want to identify as neurodivergent, there's actually no specific diagnosis required. Any person can identify as neurodivergent. And it's all about based on the person's lived experiences and differences in their thinking, feeling, and behaving. And usually those that don't want to go down that path of diagnosis just don't need any particular funding or services from any government departments. The other option that some people do, or some families do, is that they actually use the medical model to access those government services, but they only use that language in those applications or while talking to those departments. And in fact, use more identity-informed language about their own strengths and weaknesses and their identity as neurodiverse in their day-to-day lives. And it's actually up to each family which sort of model they identify with best. So we're going to have a little bit more of a look at this identity aspect. So while conditions like ASD and ADHD are widely recognised as neurodivergent, there are some other conditions and experiences that are also fit within that and may be considered neurodivergent. But again, it's just up to those who identify with that particular model and concept as to which conditions they'd like that to be in. And I could rattle off a couple of other specific diagnoses that might fall in there, but it's actually up to each individual person whether they identify as neurodivergent. Neurodivergent experiences actually vary quite widely between different individuals because every person has strengths and challenges that are actually just unique to their specific profile. And neurodiversity also acknowledges that it's not one right way for a brain to function, and that differences in our cognitive or our neurological functioning should be respected and actually celebrated. It's not a deficit or a disorder. They're just different ways of functioning, which is actually a really lovely way to support any person who feels like they're different from other people. Yeah, and that's okay. So let's have a bit of a look at the benefits of neurodiversity. So it fosters creativity. So we should embrace neurodiversity. It can lead to these enhanced creativities as diverse perspectives spark innovative ideas and solutions. We need creativity. So let's harness that. Neurodiverse individuals often approach challenges differently. Again, which is really unique, and we need to be able to consider different ways of problem solving different situations so we get different outcomes. We also want to just be inclusive of everyone, and if we can include everybody in our society so that they feel valued and empowered, what an amazing world we would live in. There's also some uniqueness that goes with neurodiversity. So each child has their own unique traits and strengths that make them special. And so if we can understand that and harness that and build on those strengths, amazing. Many neurodivergent children actually have exceptional memory skills. So again, let's harness that for learning and problem solving. Again, we talked about creativity. It's often a strong suit for neurodivergent children, leading to innovative ideas and solutions. And goodness, their attention to detail is another strength that we should harness and focus on. They're able to excel in a whole variety of tasks and projects for that attention to detail that they present. So then as parents, how are we actually going to harness this? How do we support that in their environment? I guess, it can be exactly the same for you guys as educators as well. So how about we start with minimising the distractions? Create a supportive home or centre that requires reduced distractions so that the child can actually foster their focus and relaxation for everybody around. I think often when I think about classrooms or childcare centres, there's so many pictures and things going on that sometimes that can actually be really distracting and really sensory overloaded for some children. So see if we can minimise that or have spaces within the centre or the home that has minimal distractions. We want to make sure we've got sensory friendly spaces. So children have different levels of sensory tolerances. So some get really overwhelmed from too much and some need lots. So making sure there's some space available that can promote both of those types of brain styles that might be going on for any children. And we also want to make sure that we're having this open communication about all our feelings and the needs, and not only within the family, but also within the centre, and being really open to understanding each other's needs. We also want to make sure that we support them in our neurotypical world that we live in. And so what are some of the things we can do to do that as well? So we want to make sure that we're having really clear language. Simple, clear language helps them better understand what's going on and reduce the confusion that might be happening. So an example of that is, let's just give one instruction at a time. So rather than clean your room, how about we just have one task of pick up the dirty clothes and put them in the basket. And once that task is done, then you can go back with, okay, let's pick up all the rubbish and put that in the bin. So really simple tasks. Make sure we're using visual aids. Incorporating lots of visual aids can help with understanding and also retention of some of that information. Because although some neurodiverse children have good memories, others will not, as they all have a different profile. So perhaps having a job list that's up. Here's your morning routine. These are all the things that need to happen in the morning. Perhaps in the childcare centre, just sharing when it's indoor play, when it's outdoor play, or when there's something else going on. That changes the routine up. We want to make sure we're also doing some active listening. So practicing that and actually being able to model that to the children as well. So if a child's talking to you, stop and have that interaction with them, so that then when a child is talking to another child, the child who's listening can make sure that they're paying attention because they've seen you guys do it as parents and educators. And it also helps to build some trust between the children. Here's even some more ways of what we can do, making sure we have some structured routines. We talked about that before, that there are some neurodivergent children who need that routine because they've been unable to update their system. So making sure we can provide some predictability so that they can feel secure and understand what their daily expectations are. And so perhaps having some really regular, this is what time we come inside, this is what time we do dinner, this is what time bath time is, this is when bedtime is, and just having some of those structures and routines in place. Making sure that if we identify some particular areas that children are struggling with, that we make sure we put some reasonable accommodations in so that we can meet their specific needs. So we want to make sure that we can reduce their anxiety so that they can have the best learning experience. So let's making sure that they don't have to meet everybody else's skill level, they just have to meet theirs. And we have to be okay with that. So putting some accommodations in to allow for that. And the best part that we want to do for all children is we want to promote their independence, making sure we've got those routines and accommodations there so that they can have independence. We want them to be able to thrive both academically and socially. So let's pick some age appropriate or developmental appropriate skills in there for them to build their independence. That's our job as parents and educators, is to create these independent adults. And we just have to do that one step at a time. So I'm just going to flick over a little and go, well, let's see how things work within a school environment. So a couple of things, this sort of goes back to a little bit of that medical model a little, but every school, and usually when there are children who are having some difficulties within the neurotypical world of a school, is that some individual education programs are identified for those children who struggle in that environment. And they're usually designed to meet the unique needs of the students with, again, in that government department, we use the term disability so that we can provide the right support. Now, when we think about, again, the government organisations and the Disability Discrimination Act, within the school environment, it's actually part of that act to make sure that the school is making adjustments, and they call them reasonable adjustments and accommodations to allow them to access the education that's necessary for them. And what's really important for parents in this role is you guys are the advocate for your child. And it's really important for you to be really clear and really aware of what is my child's EAP. Is it developmentally appropriate for them? Is it leading to independence? What can I do to support that? And if you can work really collaboratively with your educators, we can make sure that your child has their best experience and can learn and become those independent people. I was going to flip back a little bit around how to then do we support this neurodiversity concept with family, because sometimes not all families will be as open to the different brain styles or different behaviours and strengths and weaknesses of children. So we really want to make sure that we have a real cultural acceptance, that family is very understanding and accepting of each child's strengths and weaknesses, whether they identify as neurodiverse or not. We want every child to feel valued and understood. We want to make sure there's that open dialogue, having lots of conversations, sharing with family everyone's strengths and weaknesses so that they're aware of what's going on. And just making sure that we're educating the people around us. And if neurodiversity is the term you want to use for your family, then let people know what it is and how you can foster a really inclusive and supportive environment for your child. We also want to make sure that we support the children with their peer interactions. So it's a really important developmental step to have children who can relate well with their peers. Human beings are social creatures, and so it's important to learn the skill that goes with that. So making sure we're teaching them some of those social skills or interactions with other people so that we can have good emotional well-being. We want to make sure that we can then facilitate play dates, organise opportunities for your children to actually socialise and build friendships in comfortable settings, even if it's always about having someone come to your place. And within that, and this is where I often talk about, we need to make sure we do socialise our children so they understand how or what are some of the appropriate ways to behave in different social contexts. And I often come across parents who say, I don't take my child grocery shopping, it's too hard and too complex. I guess my question to you is, how will they learn to behave in a way that's socially acceptable if we don't teach them how to do that? Not letting them go doesn't teach them how to do that. So perhaps consider, don't have to take them every time, but perhaps consider taking them out on some trips so that we can educate them around what's an appropriate way to respond to interactions out in the world that we live in. And when we do organise those play dates, it's really important to make sure that then we create some of those structured activities so that we can help them have those social skills within the play date with their peers so that they can have really good interactions with them. And I guess my little suggestion on here is board games are a really fabulous way to have those social interactions. It teaches turn taking, it teaches tolerance, it teaches sportsmanship. They're really lovely things to be able to do. But you know what? We can also do all of those things with online games as well. So, enjoying time with your children and learning some of those things and being part of some of those online games can also be really helpful. And for some children who don't want to do the face-to-face play dates, you can do online play dates as well. And you'd just be hanging around with them just as you would in the house. So be part of that. So I'm just going to share a little take home from my presentation tonight. I know there's lots of information, but I guess my take homes are all brain styles have strengths and weaknesses, and there is nothing wrong with a neurodivergent brain. So let's take the word disorder away and change it to difference. We all find our neurokin to engage with and build relationships with. And let's change the environment to suit the brain that we are supporting. We don't need to change the brain to suit the environment that we live in. What can we do to adapt our child? Engage in their world, play games online with them, ask them about their day or their thoughts or their interactions. They may share or they may not. And it's about us being okay that they don't want to share because that's their brain style. And like all parenting, and we spoke about this in my last webinar, was build relationships with your child. Spend 10 minutes a day, 5 days a week, together, doing what they want. And be the best parent you can be to your child's brain style, irrespective of whether it's different to yours. Thanks, everyone. And I think we've got a little bit of an opportunity to perhaps take some questions.